Greetings from Jaipur. I am Dr. Samriddhi Nanda and I'm an associate professor in Department of Anaesthesia, Savai Mansingh Medical College, Jaipur. And I'm going to be talking about nerve blocks of the thorax. So basically, I'm going to be covering the description of the anatomy, the relevant anatomy or the functional anatomy for the chest wall blocks. I'm going to enumerate the blocks for you. And also, I'm going to tell you about the practical application of the blocks in different scenarios. So, the chest wall regional anesthesia is very important as it leads to better pain control both intraoperatively as well as postoperatively. There's a plethora of regional blocks available because of a newer development. Conventionally, thoracic epidural was the cornerstone, but now, because of the latest developments, there are newer chest wall blocks which are safer and equally proficient for analgesia. Coming to the neuroanatomy of the chest wall. So here we are dealing with just the anterior part of the chest wall as well as the lateral part of the chest wall. So the anterior chest wall is mainly supplied by the medial pectoral nerve as well as lateral pectoral nerve. The lateral part of the chest wall is supplied by the intercostal nerves, the thoracodorsal nerve, which is also called the nerve to the latissimus dorsi, and also the long thoracic nerve or the nerve to the serratus anterior. Also, the if we look at the individual intercostal nerves, the intercostal nerve arises from the ventral ramus of the nerves. So the dorsal ramus supplies the back part of the chest. Another branch is given off as the gray rami communicantis to the sympathetic chain. The ventral ramus continues as the intercostal nerve. So here's the ventral ramus that continues as the intercostal nerve. On the way, just anterior to the mid axillary point, it gives off a branch which is the lateral cutaneous branch, which again divides into the posterior as well as anterior branches and supplies the pretty much the all of the chest laterally. The rest of the intercostal nerve continues as the anterior cutaneous nerve, which just by the sternum, just at the lateral edge of the sternum, it pierces the external intercostal muscle as well as the pectoral muscle, and it uh, supplies the anterior skin of the chest. So important to note is the T2 to T6 nerves behave in this manner, but T7 to T12 nerves, however, they pierce the rectus sheath and supply the anterior abdominal wall. Coming to the anatomy of the paravertebral space, here we have the vertebra, and this here is the paravertebral space. So the boundaries of the paravertebral space are medially it is formed by the vertebral body, the intervertebral discs, as well as the intervertebral foramina. Anterolaterally, it is formed by the pleura, and posteriorly, it is made up of the transverse process as well as the superior costotransverse ligament. So this here is the paravertebral space. So the paravertebral space is also invested by the endothoracic fascia, which merges with the periosteum of the vertebral body and continues on the other side. This endothoracic fascia divides the entire space into the posterior as well as, sorry, this is the anterior as well as the posterior parts. So coming to the regional blocks, the important point to note is what are the indications for using these regional blocks. So as you can see on the screen, there are too many indications out here. There can be indications for surgeries on the thorax like thoracotomy, pectus repair, thoracic aneurysms, thymectomy, video assisted thoracoscopic surgeries, cardiac surgeries, rib fracture management, which is a very important indication and commonly employed indication as well. Then there can be surgeries on the upper abdomen, like esophagectomies, gastrectomies, pancreatectomies, cholecystectomies, hepatic resections, etc. In the lower abdomen, you employ these blocks in abdominal aortic aneurysm surgeries, colectomies, bowel resections, abdominal perineal resections, urogenital gynecological surgeries like nephrectomy, uteral repair, radical abdominal prostatectomies, ovarian tumor, debulking, pelvic exenterations, total abdominal hysterectomies. All of these may utilize the chest wall blocks. So there are different kinds of blocks for the chest. They're grouped under, I have grouped them into neuraxial blocks, the fascial plane blocks, other blocks like interpleural and intercostal. So conventionally, we've been using the neuraxial blocks, which are the thoracic epidural or paravertebral blocks, fascial plane blocks like PEX block, serratus anterior plane block, transversus thoracis plane block, rectus spinae plane block, retrolaminar, the rhomboid intercostal subserratus block, supraclavicular block, etc. Then there can be other blocks like interpleural and intercostal blocks also, but they are not very commonly utilized for surgeries as much. So, first and foremost, we have to prepare the patient for the blocks. So, the patient should be cooperative and he or she should be understanding enough. So, the patient evaluation is supreme. We have to explain each and every aspect of the block and its concerned risks as well as benefits of the block to the patient. Not to forget, every concern of the patient before doing the block should be explained, should be addressed, and physical examination pertaining to the block should be done. Also, a history of coagulation disorders or if there are any drugs that are affecting the thrombosis should also be taken. Along with this, there should be a platelet count as well as a prothrombin time and an INR done before we employ these blocks. At the same time, we should also have adequate preparation regarding the equipment as well as drugs. All the emergency drugs and emergency equipment, including the airways, laryngoscope handles, plates, bougies, stylets, syringes, needles, everything should be ready beforehand. Also, not to forget the entire local anesthetic systemic toxicity protocol should be followed, and 20% lipid emulsion should be kept at bay. So, coming to the thoracic epidural block, thoracic epidural block is one of the earliest blocks that were employed for the chest wall regional anesthesia. So, the boundaries of the epidural space are posteriorly it is bounded by the ligamentum flavum, laterally by pedicles and intervertebral foramina, anteriorly by posterior longitudinal ligament, whereas the contents of the epidural space are fat, blood vessels, nerve roots, loose connective tissue, etc. So the thoracic epidural is done in between T1 to T12 levels. There are certain absolute contraindications like patient refusal as well as severe coagulation abnormalities that have to be kept in mind. Relative contraindications include sepsis, fever, infection, elevated ICPs, then prior CNS disorders, multiple sclerosis, etc., back surgeries, back pain, thrombocytopenia, as well as other bleeding disorders, or placement in anesthetized adults or placement through tattoos. These form the relative contraindications. Now, the approach to the thoracic epidural is different from the others. So, in mid thoracic level, the spinous processes are steeper. So, there has to be a sharper and a more caudal angle of insertion. Also, paramedian approach is preferred rather than median approach. The average skin to epidural space depth is about 3.5 to 7.5 centimeters, and AP diameter of the posterior epidural space is less. Likewise, since the AP diameter is less, lesser volume can be accommodated. So typically, they say about zero point 0.7 ml per segment of volume is required for thoracic epidurals. So the distribution of the thoracic epidural is bilateral and it's going to cover few segments. And whatever dermatomes are covered, it's going to be covered all over the chest, anteriorly as well as posteriorly. So the thoracic paravertebral block, coming to this, because thoracic epidural block will be covered in greater detail in another seminar. So let's quickly come to the thoracic paravertebral block. So the thoracic paravertebral block, the concept is given by Hugo Salim in 1905, improvised by Lavin in 1911. It is a very safe, effective block. It's just like the thoracic epidural, except that there is unilaterality of the block of the paravertebral nerves. Both analgesia as well as anesthesia can be provided, and the targeted nerves are paravertebral nerves of the corresponding segments. So, coming to the paravertebral space, like we've already talked about the anatomy of the paravertebral space, What are the connections of this space? So laterally, it is connected to the intercostal space, as we can see. Medially, contralateral paravertebral space. Cranially, perhaps it goes to the cervical region. And caudally, it ends up to the original psoas muscle. So the thoracic paravertebral block, how is it done? So there are three techniques to doing thoracic paravertebral block. First is the loss of resistance to air or saline. The second is the nerve stimulator guided, and the third one is the ultrasound guided. So when we're doing the loss of resistance to air and saline, the position of the patient should be sitting or lying down. The neck be flexed and back arched. Shoulders should be drooping forward. The position is just very similar to the spinal position or the position that we put for the epidurals. Then after that, we have to mark a point which is about 2.5 centimeters to 3 centimeters lateral to the T4 spine. The needle is advanced posterior-anteriorly, perpendicular to the skin. Loss of resistance is checked, and if we encounter the transverse process on the way, then we have to walk inferiorly till the loss of resistance is obtained. So it should not go beyond 1.5 centimeters from the level of the transverse process depth. Also, at all times, you have to ensure that the bevel points laterally so as to not injure the pleura. Like I said, the nerve stimulator guided technique is also used. So, with the nerve stimulator needle, twitchings of the intercostal muscles corresponding to the ventral ramus at about zero point 0.4 milliampere should be elicited. Ultrasound guided technique can also be used. As we can see, the transverse processes are seen out here. This is a long axis scan of the back of the chest. So in between the two transverse processes, one can make out the costotransverse ligament, and the paravertebral space just lies above the pleura. So the needle should come right up till here. Okay. And we have to make sure that we do not injure the pleura, otherwise there are going to be chances of complications. So what are the complications of the thoracic paravertebral block? It fails in about 6.1% adults. There is vascular puncture in about 6.8%, hypotension about 4%. It may go epidurally or intrathecally in about 1% of the patient. Then pleural puncture is only about 0.4%, and less than 1% may experience pulmonary hemorrhage or ipsilateral Horner syndrome. So, like I said, thoracic paravertebral block is very similar to the epidural block, except that it is unilateral. So, unilaterally, the dermatome is going to be blocked in the same number of dermatomes anteriorly as well as posteriorly. Coming to the pectoral and serratus plane blocks, they are relatively newer blocks. The blocks were given by Rafael Blanco in 2011, and he uh, very nicely he propagated the employment of this very important block. It's a high volume interfascial plane block, and these were actually developed as safer alternatives to conventional blocks, both for anesthesia and analgesia. Initially, it used to be said that it's only meant for analgesia, but recent case reports have come up which say that anesthesia is also provided by PEX blocks. So PEX 1 and PEX 2 basically targets the following nerves. The PEX 1 targets the medial pectoral, lateral pectoral nerves. PEX 2, the medial lateral pectoral nerves, lateral cutaneous branches of the intercostal nerves, long thoracic and thoracodorsal nerves. So PEX 2 is an injection with that includes PEX 1 and a deeper injection, as we'll see in forthcoming slides. So PEX 1, the technique is that patient is made to lie supine with ipsilateral arm by the side, head turned towards the contralateral side. The target anatomical location will be the mid-clavicular line, and that is followed along the second and the third rib. The inferior end of the probe is tilted towards the axilla. The probe is parallel to the deltopectoral groove, and we target a plane in between the pectoralis major as well as pectoralis minor, and deposit about 10 to 20 ml of the local anesthetic drug or local anesthetic mixture into that space. PEX 2, however, it has the same position. You should put it in supine position with ipsilateral arm by the side, head turned towards the contralateral side. It is targeted in the mid-clavicular lines, again in the second, third rib. Inferior end of the probe is tilted towards the axilla, similar to PEX 1. But the targeted plane here are two. Plane 1 is actually the plane in between the P major and P minor, which is the same as PEX 1 block. But the second plane is plane between P minor and serratus anterior. So injections can be done both from superficial to deep or from the deep to superficial. My personal preference is from deep to superficial. So the total volume deposited per plane is 10 ml. So coming to the demonstration, the PEX 1 block. The PEX 1 block is done in between the uh, PEC major and PEC minor. As you can see, there's a facial plane in between and we're depositing the drug here. So this is the area of coverage of the PEX 1 block. Whereas PEX 2 block is done in between the P minor and serratus anterior. And this is the plane in which we're depositing. Here, the coverage is wider because it includes PEX 1 as well as the lateral part of the chest wall is also included here. Complications, they are rare, but potential complications might occur. They can be pneumothorax, they can range from infections to local anesthetic systemic toxicity if you're not careful about the drug dosages or arterial puncture. Then vascular puncture may also occur, and field block is another complication. What about the serratus anterior plane block? So it is performed more lateral and posterior to the pecs 1 and 2. The targeted nerves are lateral cutaneous branches of the intercostal nerves, long thoracic nerves, thoracodorsal nerves, and intercostal brachial nerve. For this, the position of the patient should be supine or lateral decubitus. If the patient is supine, the ipsilateral arm is abducted, and the lateral decubitus position, the operative side is up and the arm is flexed forward. The plane that is targeted is in between the it is just superficial and deep to the serratus anterior muscle, and for this what we need to do is the probe should be placed in a parasagittal plane below the clavicle. So we start from the mid clavicular line, and then gradually when the third or the fourth intercostal, as soon as we reach the fourth intercostal space, we just take the probe laterally, move laterally right up to the mid axillary line, and then tilt the probe with the inferior end towards the posterior axillary line. So after that, we identify the latissimus dorsi as well as the serratus anterior muscle. So like I said, the serratus anterior muscle has two planes, a plane superficial to it and a plane deeper to it. So for the block, one has to place 10 ml in each plane. So this is the serratus anterior, and we are placing the drug underneath this plane. So we can do another injection here that is in the superficial plane as well. So this is the plane. And the area of distribution of the serratus anterior plane is lateral part of the chest. What about the complications? They are similar to PECs. They are rare with ultrasound guidance, but there can be complications like pneumothorax, vascular puncture, nerve injury, and infections if you're not very careful. Coming to the erector spiny plane block, it is a very important block and has recently gained acceptance and popularity. It was first described in 2016 by a paper by Michael Ferrero to manage the thoracic neuropathic pain. This has found a multitude of uses ever since. It is relatively young and it has tremendous potential. So, targeted nerves are basically dorsal rami of the spinal nerves, but because the space is continuous and the fascial plane is continuous, it will even spread transforaminally into the epidural space and eventually cover the visceral analgesia as well. So there is craniocaudal spread aided by the thoracolumbar fascia, and it extends 3 to 4 levels cranially and caudally. So for this is a very easy block, and the patient may be lateral, sitting or prone. The targeted anatomical location would be the vertebral level by counting. We have to identify the target vertebral level by counting down from C7 spinous process or from the first rib. So parasagittal, the long axis of the probe is placed in a parasagittal plane. So we can identify gradually from the spinous process to the lamina to the transverse process and the rib. So then again, we take the probe right up to the transverse process and we identify the tip of the transverse process. So the targeted plane is posterior to the tip of the transverse processes and 10 to 20 ml of the solution is deposited. So when I say solution, solution actually means it can be an anesthetic solution that is about, let's say, less than 0.25% of bupivacaine or ropivacaine, or it could be analgesic. This is the analgesic concentration, and it could be anesthetic solution also, which is higher than this concentration. So this here is the rectus spinae plane block, and as you can see, this is the ultrasound image of the rectus spinae plane block. We've identified the transverse process here. This one here is the erectus spinae muscle, and we bring our needle right on top of the transverse process and lift the rectus spinae off of the transverse process by 10 to 20 ml of the solution. So the area of distribution is typically posterior, and it's going to cover about four segments: cranial and quadrant. Likewise, the complications are rare. The potential complications may be infection, blast, allergy, vascular puncture, or field block. Coming to the newer blocks, there are a lot of newer blocks, out of which only few I'm going to discuss. So one is the retrolaminar and another one is the midpoint transverse process block. So retrolaminar plane block, the targeted nerves are again the ventral and as well as the dorsal spinal rami. It's very similar to the erectus spinae plane block, except that the probe should be little more medial, just posterior to the lamina. And the lateral cutaneous branches of the intercostal nerves can also be involved in this. Similarly, the rhomboid intercostal and subserratus plane block, this is actually a two injection block in between the rhomboid and intercostal and just deep to the serratus. Here again, the targeted nerves are the T2 to T11 dermatomes ventral, dorsal, spinal rami of the thoracic intercostal spinal nerves. Coming to the adjuvant blocks, there are certain blocks that are not the mainstream chest wall blocks, but they are adjuvant blocks. Just like the transverse thoracic plane block, which specifically targets the anterior cutaneous branches of T2 to T6 intercostal nerves and the sympathetic plexus around the internal thoracic tree. So the patient positioning should be supine. The probe, the long axis of the probe is placed parasagittally in the mid-clavicular line between the third and the fourth rib spaces. And we target a plane in between the internal intercostal muscle and the transversus thoracis muscle. 10 to 20 ml of on each side should be given to target the anterior cutaneous nerves. So like we see, this is the rib and this is the P major muscle. Just underneath the P major muscle is the intercostal muscle, and there is a thin paper-like muscle that's called the transversus thoracis muscle. Just underneath this is the pleura. So there's a plane underneath the transversus thoracis muscle in between it and the pleura. So we have to target a plane in between the TTM as well as pleura. Then there are supraclavicular nerve blocks. Very often during breast surgeries, we tend to miss this important part of coverage. Also, the the transverse thoracic plane block is also missed out. There are a lot of nerves, the anterior cutaneous nerves get missed out when we are trying to block for breast surgeries. So supraclavicular nerve block should also be performed alongside, because unless we do this, the upper part of the chest will be missed out on. So these are the supraclavicular nerves, and all we need to do is just do a subcutaneous injection underneath the clavicle to block the supraclavicular nerves. So basically, it's a field block. Coming to the intercostal nerve block, the intercostal nerve blocks target nerves which are the intercostal nerves from T1 to T12. The patient positioning is prone, can be sitting, can be lateral decubitus with a painful side up. The targeted anatomical locations, the targets should be in the upper ribs about 4 to 7 centimeters from the spinous process, and then the lower ribs 5 to 8 centimeters from the spinous process towards the intercostal groove. So the target plane is the intercostal groove, and you have to give 5 ml of the solution per level. At least 3 levels are to be blocked. One is the target, another one up, and another one down. So at least 3 levels should be targeted to provide good analgesia and anesthesia. So this is the intercostal nerve block. As we can see, the these are the ribs, and the neurovascular bundle is present in between a plane, in between the pleura and innermost intercostal muscle on one side, and external and internal intercostal muscles on the other side. Interpleural block is not used nowadays a lot. So but however, it used to provide better analgesic blocks. It used to provide good analgesia, but since there is a high risk of systemic toxicity, that's why we do not use it anymore. Now, after all of these blocks, it is natural to be confused. So let's solve this conundrum. So for anesthesia and analgesia, the thoracic epidural and paravertebral blocks and PEX 1 and PEX 2 are the only blocks that are utilized. For analgesia, serratus anterior plane block, rectus spinae plane block can be utilized. And all the other facial plane blocks can be utilized. So far for anesthesia, only these three blocks are purported to be useful. So let's get back to the anterior and lateral chest wall blocks. So for the blockage of the medial pectoral nerves as well as lateral pectoral nerves, what we need to give is PEX 1 or PEX 2, infraclavicular brachial plexus block. For the infraclavicular brachial plexus, what we need to do is infraclavicular brachial plexus block. For the thoracodorsal nerve to serratus anterior and intercostobrachial nerve coverage, we need to give the serratus anterior plane block. For the paravertebral nerve coverage, we need to give a paravertebral block. For the dorsal ramus, we need to do the rectus spinae plane block. For the intercostal nerve, one can do the intercostal nerve block. The lateral pectoral cutaneous branch will be covered by the SAP or the serratus anterior plane block, and the anterior cutaneous branch will be covered by the transversus thoracis plane block, the pecto-intercostal block, which I have not covered in this seminar. So, as a take-home message, the thoracic epidural and thoracic paravertebral blocks are no more the only options available for anesthesia and analgesia. It is vital to understand the nerve distribution for a good analgesic coverage of the chest. Thoracic paravertebral block still is the gold standard for hemithoracic anesthesia, and more than one type of block may be necessary to block the desired segment of the chest. These are my references, and that's all for now. I would like to specially thank Dr. Dudvish Bhoi for providing me with the images of the blocks. Thank you so much, and thank you for your patient listening.